So today I want to talk like sort of a bird eye view of sickle cell disease, of where we've started and where we are now. And then just a quick review of the pathophysiology and the complications that explains a lot of the data that we see in our practice, some disease modifying therapies and updates in that, and some of the media attention that recently it's gotten to, including gene therapy and transplantation, and then the burden of disease. And then I'll talk about what we have done at Inova and our dedicated sickle cell program, and that has really changed the landscape of sickle cell care in the DMV area. So sickle cell disease, it dates back to the 1700s, where they would talk about these painful episodes in African-American men and women. However, it wasn't until 1910 where sickle cell was first discovered by an internist who looked under a smear of a dental student with these painful attacks and described it as the sickle cell RBCs. Then it wasn't until the 1950s that we understood the genetic component of sickle cell disease. And I like to point out, this was the first time we understood that there was a genetic component of disease. And that led to research and development of treatment options for many other genetically influenced diseases, but then sickle cell got left behind. It wasn't until the 1970s with the Sickle Cell Act that it started getting a little bit more attention, but also created a lot of hysteria and discrimination and alienation of patients. It wasn't until the 1980s and 1990s where we realized that increased fetal hemoglobin can be a curative or a transformative option for sickle cell patients, and hydroxyurea was not approved until FDA in 1998. And then in the 2017-2019 era, we got two other treatments approved, crizanlizumab and voxelotor, that have subsequently been off the market or being used less. And then just December of last year, gene therapy was approved for sickle cell disease. And then we took a huge blow in the sickle cell community in September, where one of our disease-modifying therapies was taken off the market in 2004. So this prolonged history, very slow to treatment options, very slow to improving outcomes for patients. Looking at I want to share some statistics to sort of set the ground for what we want to talk about and what we see. It's rare, but it's not as rare in terms of practice, because we do see a lot of sickle cell patients because of their acute care utilization. So historically, it's 1 out of 365 African-American patients, 1 out of 16,000 Hispanics in the population. In a study of almost 42,000 Medicaid recipient patients with sickle cell disease, there's discovered that there's 134,000 hospitalizations per year, and 20% of sickle cell patients had 3 or more acute care utilizations. So it's quite a lot. The chances of us in whatever practice we go into to have a sickle cell patient and take care of them is quite high. So no matter what we go into, understanding sickle cell disease is imperative. Furthermore, when we think about sickle cell acute care utilization, those patients are 3.5 times more likely to have an ED visit that results in a hospitalization. They're more likely to be seen in the ED, and they have about 15 admission or hospital days per year. 82% of sickle cell patients that were discharged from the ER were returned within 30 days. 58% of those resulted in an admission. So it's quite a lot. Furthermore, if we think about it, a lot of these patients are young people in the 18 to 30s range. They are not able to properly transition from pediatrics to adults. Our med-ped colleagues could agree. There's a paucity of adult providers, so patients get lost to care. So they're using the hospital for their disease management, and that accounts for a lot of mortality and morbidity that we'll see, and a lot of hospitalization. The national length of stay, it's about 6 days currently for sickle cell patients. And as I talked about, it's a lot of the 20 to 30-year-olds because of lack of proper transition from pediatrics to adults. And so they're using the hospital because they had an acute pain attack. Then they go home, they don't have up with, and then they're they're back in the hospital. There's a high lifetime cost, so a patient will cost about $8 million over a lifetime and about $3 billion overall sickle cell healthcare cost. So when we talk about gene therapy down the road, and there has a price tag of $3 to $4 million, it's still cheaper than the average lifetime cost of having sickle cell disease. What I wanted to talk a little bit about is that hospitalists face a lot of challenges in caring for sickle cell patients. Why is that? And I've experienced it firsthand. It's either we're not we're getting mixed signals of how to properly manage the pain. It's hard to discharge patients to where, who's going to receive them, who's going to continue the care of them, right? Are we working closely with our HEMON colleagues to really manage the patient? Do they have a care plan? Do we know what to do? Do we understand the difference between acute and chronic pain exacerbation? So there's a lot of gaps in care. So today I'm hoping to help fill in some of that gap, and I'll always be a resource to all of you guys at any point in time. I'm just down the street. Just quickly, in terms of the pathophysiology, the genetics of it, it's a mutation in the beta globin gene at codon 6 from a hydrophilic glutamine to a hydrophobic valine. And depending on how many mutations you have, there's the genetic types of sickle cell disease. So patients with trait only have one mutation. Patients with anemia, where they're SS, they have two mutated copies. Patients with SC have a valine change and a lysine change, so they're a C genotype, and then depending on the beta globin, whether you complete lack of beta globin production or some production, you have sickle beta plus or beta thalassemia. What is really phenomenal and interesting about sickle cell disease, even within these genotypes, I haven't even covered the Arab and Punjab phenotypes, but there's significant heterogeneity. So if you're like, I had this one SS patient barely came in, and this other SS patient that was like in and out, it's because there's still heterogeneity that we don't quite understand, even within the same genotype. And there's a lot of work to be done of who's the right candidate for what treatments and what modalities. In terms of the basic mechanism of that, is that S hemoglobin does not hang on to oxygen well, so it deoxygenates. When it deoxygenates, there's this phenomenal mechanism of polymerization, and the hemoglobin polymer subsequently crystallize, and there's a lot of nuances to that I won't get into in terms of the transit time through the capillaries when it's deoxygenated before it can reoxygenate, as well as how soon it sort of polymerizes. But once the hemoglobin S concentration increases and polymerizes inside the cell, you get that impressive rod-like structures and sickling of the RBC and changes in the membrane. And then you get this pretty impressive phenomena of just not just polymerization, but hemolysis and sickling event that leads to the vaso-occlusion. There's a lot of endothelial injury and inflammation. So it's not one mechanism, but a component of multifactorial events that leads to the complications. And so this chronic ischemia reperfusion injury has not only acute implications, but chronic, all profound, the different organ systems in the body. It's really sad. We haven't made significant stride in mortality in sickle cell disease. So from the 1970s to the 2000s, it's still around 40 years of age. The other component to talk about is the complications that we see. So as you can see, every organ is impacted. Blood goes everywhere. Changes occur everywhere. There's the acute complications and the chronic complications. In terms of a hospitalized setting, I'll touch on some of the more common acute complications that we see. One of my colleagues and mentors calls it the nociceptive soup of vaso-occlusive crises, because it really is a profound multifactorial event that leads to vaso-occlusion, inflammation, tissue damage and injury, and significant pain. That pain can be localized to the hips, chest, joints, or it could be diffuse, it could be migratory. The triggers could be infection, it could be stress, it could be changes in weather, plethora of events that cause that. And it's really the highs in the 20 to 29-year-olds, and that's where we start seeing increased morbidity, mortality, opioid overuse as well. And the more frequency of VOCs, the vaso-occlusive crises, the higher likely predictor of mortality. And if you look at, in terms of organ dysfunction and other comorbidities, patients with higher VOC rates have almost more components of profound damage from sickle cell disease, where they're looking at cerebral changes, GYN changes, iron overload from excessive transfusions, acute chest, renal failure, bony damage, really profound implications. The saddest thing is when you see a 40-year-old on dialysis with a stroke, frequent transfusions, aggressive pain on high doses of opioids, and they're incredibly miserable. And if we don't do something early on in their young career and trajectory before their transition, and it becomes almost too late. In terms of management for acute crisis, and I'll talk a little bit more about it when I review what we do at Inova, but with ASH guidelines as well. So really door to first IV opioid medication should be within 60 minutes. There's some talk that CMS is going to require a 30-minute window eventually. So the discussions are ongoing, but giving IV opioids, giving NSAIDs, potentially considering ketamine in opioid refractory patients, adjunctive therapy. Some institutions will offer mental health support, massage therapy, acupuncture, and those sort of things. Using individualized care plans is key. When the patient in an outpatient setting with their sickle cell specialist has developed a care plan for the ER, care plan for the hospital, so then there's no guessing. You come in, you know exactly what you're getting. The doctors know what to give you. Then they can focus on analyzing, why were you in a crisis? Do you have an infection? Is there something else going on that causes that sort of issue? So frequent assessment is key of monitoring to make sure the NLGs is appropriate and not over treating patients either. Hydrating patients who are hypovolemic and not overhydrating patients. Usually 5 to 7 days of NSAIDs, and there's within the sickle cell community, there's talk about really being aggressive about monitoring for opioid failure, so not allowing patients to stay for weeks on a PCA, which is the problem we do have at Inova, admittedly. Patients are staying 3, 4, 6 weeks on a PCA, and they're just go home and withdraw and come right back. So some things to consider, and not using corticosteroids because it can actually exacerbate a crisis. And there's no data that a simple transfusion is helpful in improving an uncomplicated pain crisis. So not transfusing patients unnecessarily. In terms of the inpatient pain management, again, we can't emphasize enough the use of individualized care plans for patients. And so then the patients know what to expect, the providers know what to give. Using a PCA instead of intermittent opioid bolus dosing, it's safer, it's more effective. You're not relying on a healthcare professional to come administer the opioid either. It does really correlate with lower readmission rate, shorter length of stay as well, so an overall improved outcome. Also avoiding IV diphenhydramine and IV Benadryl and sickle cell, and using oral agents and other combinations. Thinking about restricted care plans for patients who are living, quite a bit of their lives in the hospital and having chronic pain and opioid failure. So the group at Yale, Dr. Roberts' group, developed this beautiful plan of not only do you come in with a PC, but then patients come to sort of start an oral tiered plan of pain in order to transition them off of the PC and have a regimen that they can go home on and discharge on. So then their outpatient team can then wean them down further and help them with their pain. And that's sort of what we modeled a lot of our sickle cell treatment after. Other thing we need to be mindful of in a hospital is the type of pain the patient is having, being mindful of the opioid epidemic as well as chronic pain, and working with the sickle cell specialist closely of how is the patient's disease overall being managed, and not just utilizing the hospital and talking with the team. It's really hard for you on an inpatient side to think about these things, but working with the outpatient team is key to ensure that patients are well plugged in and there's a significant attention to disease-modifying therapies and overall treatment in the outpatient setting. The next company you'll likely see quite a bit is acute chest and hospitalized patients. It can be common. It's more in the adults, it often happens once they've been hospitalized and they may be on a PCA, they may be getting significant IV fluids, and the way we have to think about it is more of a clinical diagnosis, because the X-ray imaging can sometimes lag, about to 12 hours, and being mindful of the patient's clinical status and high suspicion for acute chest, early course in admission, because it can be related to high morbidity and mortality. And there's some data with patients with acute chest can also develop stroke. So the degree of whether you do a full exchange transfusion or a simple really depends on the clinical status of the patient and how they are. And there's some data that shows there's a difference in how pediatrics are managed with acute chest versus adults. Pediatrics are recognized more often. They're more likely to come in with a fever, whereas adults are not as quickly recognized. They may not have a fever. They may have sort of like some coughing, some chest pain, some maybe X-ray findings, maybe not. And there's high mortality in the adults, because I think overall we just are not paying as aggressive attention to it as we ought to. In terms of management, antibiotics, if there's an infection component, which oftentimes if you have an infiltrate on an imaging, it's hard to tell what's infectious, what is not. So a third-generation cephalosporin and a macrolide, considering oxygen therapy. Again, transfusion is based on the clinical pictures to the degree of transfusion in coordination with hematology. ensuring patients have appropriate fluid status and not overhydrating them. And the key really is prevention. Prevention from when they're admitted, prevention in the outpatient setting, use of disease-modifying therapies. There's an 80% chance of recurrence. So patients who have recurrent acute chest really need aggressive outpatient care to ensure their disease are better managed. A stroke is another complication that occurs in sickle cell patients that needs immediate attention. And we've had at our institution where patients have sat with a stroke and not recognized or not treated properly. So we really need to be mindful of that. In the early years, it's more of a hemorrhagic picture, later turns into more of an infarctive picture. The management of that also depends on the resources, the timing of the stroke, whether it's hemorrhagic or infarctive, and working closely with neurology and hematology for exchange transfusion versus TPA in certain cases. In terms of chronic complications, as you can see, it's quite profound. It's everywhere. This is one of the toughest conversations I have with patients. Historically, they think if I don't have pain, my sickle cell disease is well controlled. And then you check a urine microalbumin and they have significant microalbuminuria and they have pulmonary hypertension and they have osteonecrosis. So for us in the inpatient side, it's important to be mindful of some of the chronic complications that can impact their presentation to the hospital and their hospital course, but also reiterating to patients that there's more to pain, more than pain in sickle cell. There we go. Chronic pain is one of the biggest issues we have in sickle cell disease, helping patients understand what is chronic pain, what's an exacerbation of a chronic pain, what's an acute pain, and trying to understand that better and using non-opioid modalities or partial agonist opioids. I will say it's really impressive. I've had patients who've done gene therapy, so transformative. They barely have any S level left of a trait status, hemoglobin completely normalized, and they're still coming in wanting IV opioids and IV Benadryl because they think they're having a crisis. So it's very profound. And we have to be mindful that patients are not dismissed and not believing their pain because there's still a lot of osteonecrosis and bony changes and inflammation that occurs. But it's about how do we properly manage that? And do we do opioid rotations? Do we do gabapentinoids? Do we make sure the disease is aggressively controlled? Opioids induce hyperalgesia. It's quite pronounced, and making sure that we're mindful of that. There's this concept of ensuring that patients with sickle cell disease don't go over 90 oral morphine equivalents a day to ensure that they're not developing opioid-induced hyperalgesia and allodynia. And this, again, requires a multi-D approach. I'll say in our clinic, when we've incorporated talk therapy to patients, we fully subsidize it and we allow the patients to have a therapist. It's really helped us with teaching them how to understand their chronic pain and understand what's an exacerbation of a chronic pain versus a true crisis, and also understanding how their anxiety and depression can lead to the perception of pain and help us actually wean patients off of opioids and reduce their hospitalization. So it's very intertwined and requires quite a bit of collaboration approach. Nephropathy is pretty common. Sickle cell patients are more prone to developing AKI in the hospital and ATN. It's quite pronounced. Their serum creatinine may be okay, but they have significant micro and macroalbuminuria that really impacts their care. And it's quite daunting. There's up to 60% of adults have nephropathy in sickle cell disease, and it can be related to, poor outcome and about 11% mortality. ACE and ARBs are renoprotective, so we oftentimes will put patients on these agents and monitor them closely, managing their hypertension. There's some data that hydroxyurea may be renoprotective. There's a study that's still ongoing, but hopefully we publish soon that'll provide more information on that. Again, it's unclear what's the optimal dosing of hydroxyurea to be renoprotective, but the idea is if you aggressively control the sickle cell disease from the get-go, then you're less likely to have insult to the renal system. Cardiopulmonary disease is also quite profound, looking at pulmonary hypertension, diastolic dysfunction, and these other components. So we have to be mindful of not over-transfusing, over-hydrating patients, and just being aware of that. I do see a lot of diastolic dysfunction and lower extremity edema. And then in the hospital, somebody gets diuretics to help with the edema. Now they're dehydrated and they go into a crisis. So it's always like a very delicate balance of being mindful of patients' cardiopulmonary status. Other chronic complications is sickle cell retinopathy is pretty common, especially in SC patients. Skin ulcerations with superimposed infections. Iron overload is a really big problem because patients are getting indiscriminate transfusions and now they're significantly iron overloaded. So we've been trying to be really aggressive about using chelation, monitoring for side effects of chelations and cardiac MRIs when necessary. And then the avascular necrosis that can lead to significant chronic pain and changes. Okay, so disease-modifying therapies. We published a paper recently that looked at the different mechanisms of targeting sickle cell disease. And I think what we'll see in the future is similar to other chronic illnesses like diabetes, asthma, hypertension. You may need multiple agents to really achieve appropriate and good disease control. So there's some agents for inducing fetal hemoglobin that is protective and prevents that significant polymerization. Hydroxyurea is the only one that's been FDA approved. Currently, there's some clinical trials with an agent called FTX 6058 through Fulcrum Therapeutics. They have initial studies that have shown impressive increase in fetal hemoglobin without the cytopenias and fertility concerns that you see with hydroxyurea. There's another agent in trial, hemoglobin polymerization inhibitor. So it binds to the alpha chain of the hemoglobin molecule and it prevents the polymerization. And with that, voxelotor was the agent that we're using quite a lot, and that just got taken off the market that I'll talk about. Osivelotor is a more enhanced version of that and currently in clinical trial. There's P-selectin blockade. So in the vasculature, a lot of the endothelial vaso-occlusion happens by upregulation of P-selectin. So crizanlizumab is an agent that's been FDA approved to block P-selectin and lead to reduction in vaso-occlusion. Inclacumab data should be coming out in the coming months. It's a longer acting. It's an injection every 3 months versus every month. There's pyruvate kinase activators, PKAs, mitapivat and topivat that have some data recently in sickle cell disease. So more on that to come. And then there's agents being developed for acute VOC treatment, heme scavengers, looking at complement changes as well. So there's a lot of ways of targeting sickle cell. We used to have a few more tools in our toolbox, and now we're only back to 2, hydroxyurea and crizanlizumab. So it's quite sad in the clinic when you don't have as many tools to treat patients with aggressive disease. Hydroxyurea is a fantastic drug. It's been around. It's the one we have the most data on. It's very well tolerated. We started in children as young as 9 months of age. There's a lot of data in support of hydroxyurea, reduces hospitalizations, frequency of VOCs, acute chest, transfusions. And I've seen it firsthand, adults that we start on hydroxyurea and you escalate them to their maximally tolerated dose, and they do really quite well. So it's a great drug. It has, improved mortality and morbidity as well. However, it's not very well utilized across the country. This data is from up to 2016, where it showed about 40% of patients who are on hydroxyurea, who should be on hydroxyurea, are on hydroxyurea. And we see that quite a lot. So some patients have these fears and anxieties about hydroxyurea and they don't understand it. They say, well, it's a chemotherapeutic agent. I don't want to take it, or it made my hair fall out, it made my nails, black, and all these concerns. And then providers similarly may not be pushing hydroxyurea, especially if a patient who doesn't have as much pain. So it's not utilized as frequently. So we're working on developing ways and improving that. And I think CMS is actually looking at hydroxyurea utilization as well in the coming months. Voxelotor, as I talked about, or Oxbryta, is an agent that was FDA approved in 2019 and voluntarily withdrawn from the market. In September, it binds to the alpha chain, and basically it allows the cells to hang on to the oxygen longer, so they're not polymerizing. And so you see an improvement in hemoglobin. So patients have an average about improvement in 1 gram per deciliter in their hemoglobin. And it's a sustained effect. And you see the dose-dependent manner. And it was about, the FDA-approved dose was 1,500 milligrams with that drug. And there's a lot of emerging data that use of voxelotor did reduce in VOCs, had some protection in nephropathy, as well as allow patients to have improvement in utilization of opioids. In our center, sorry, this goes quite slow. Here we go. At our center, we looked at hydroxyurea utilization on impact on admissions for vaso-occlusive crises, as well as transfusion. And we showed that using voxelotor was actually helping patients have less vaso-occlusive crises and less admissions for VOCs. It as well as led to a reduction in the total of blood utilization in our institution. And that was the data we used to actually get voxelotor on formulary at our hospital, which was really exciting. However, in September, the manufacturer, which is Pfizer, made the decision to voluntarily withdraw the drug. Their rationale was voxelotor and pediatric patient, they were looking at it at transcranial Doppler studies, TCDs, and they showed that while the TCD values improved in those pediatric patients, there was an unbalanced death in those who received voxelotor than didn't, and a lot of that death was to malaria. But it makes kind of sense because if you're improving the RBC live, then malaria is now more of an issue. And it wasn't really much of a problem in the US. I think it's more of a geographic issue. They also have a registry data that's collected. It was mostly for publication purposes, but it was looking at rate of VOCs in patients who are using Oxbryta. And there was a tick up, maybe a signal for increased VOCs in patients on this agent. But it wasn't taking into account the chronic pain phenomena and acute care utilization for other etiologies. As you know, anybody with sickle cell disease who goes to the hospital, they're labeled as a crisis before anything else. So the data, doesn't support quite the decision that was made to withdraw the drug. And it's been really hard in the clinic because there's patients who are iron overloaded or significant alloimmunization who can't get transfusions, who did really well on this drug and now were taken off and without having a decision or a choice in the matter. And so it's been, quite profound impact on us and the care that we deliver to our patients. And what we have seen is that there's rebound hemolysis, worsening anemia, patients going into acute VOCs and needing hospitalizations. There's a high, more psychological distress of what do I do for my disease now? Who's going to help me? There was always a lot of historical mistrust in the healthcare system, and this just sort of validated their concerns, And for us in the sickle cell community and a lot of sickle cell programs, we don't have a lot of staff. We don't have a lot of people who want to work in this field. So we're all operating by bare bone. And now you have quite a bit of your patients really sick and their treatment's gotten taken away. So it's been really stressful trying to figure out how to navigate and help our patients through that time. And couple that with the IV fluid shortage has been a pure nightmare. Crizanlizumab is the other agent, which is the monoclonal antibody, the pre-selectin inhibitor. The initial study that led to the FDA approval showed in a dose-dependent manner, it helped reduce vaso-occlusive crises in sickle cell patients. And it also lengthened the time between crises. There's some long-term data that indicated that perhaps even in patients who discontinued the agent, they still had ongoing benefits. So it's like a longer lasting effect of crizanlizumab on VOC occurrence. However, in a subsequent study where they're looking at additional dosing of 5 milligrams per kilogram versus 7.5 versus placebo, there was no difference. And that actually was very discouraging for us in the sickle cell community. There was a subsequent study that showed crizanlizumab may be helping patients with priapism and reduction in priapism. So in our clinical practice, it's very hard to know who's going to respond well to crizanlizumab and who won't. Some patients do really well with it. Others actually triggers a crisis, and some are like, I don't know if it benefited, so why would I come in once a month to do this? And it's fair. And so for these reasons, actually, the EMA removed the marketing authorization. So it's not really being utilized in the European countries. We still use it in the US because there's some patients that do benefit from it. And males who've had like frequent priapism will try it and see if it helps. But again, it's really back to the drawing board with just hydroxyurea in terms of disease-modifying therapy. Another subset of patients we need to be mindful of is pregnant sickle cell patients, because right now when patients are pregnant, we take them off their hydroxyurea, the disease-modifying therapy, and we're kind of like, good luck, I hope you do okay, So one of the things we've been looking at and trying to lobby for is being more mindful of how to treat these patients properly and utilizing a transfusion protocol or even an exchange protocol. We don't have a lot of data. There's not a lot of studies because of the nature of, already a difficult population, a rare disease, and then you take pregnant patients, you can't really quite do randomized clinical trials on that. But our practice has been to really be aggressive about transfusion therapy and making sure that we're able to keep up their hemoglobin, because maternal anemia has significant complications to the baby as well, not just the mom. And there's data that using a transfusion protocol does help with the recurrence of VOCs and some complications. Next up topic I wanted to touch on briefly was transformative and curative therapies. Really, the most important thing to note is that cure only occurs with bone marrow transplant. Finding a donor is really difficult in sickle cell patients. So there's a lot of strategies with haploidentical patients and trying to optimize it from that regard. We collaborate a lot with Johns Hopkins and UVA to have our patients evaluated. It's very labor and resource intensive, so not all patients qualify, and it's not something available to everybody. But we have to be mindful, because when we think about gene therapy, the media really hypes it up as a cure, but it's really not a cure. It's more of a transformative therapy. We still don't have long-term data on that, but there's been like as you can see, a prolonged road to gene therapy, not just in sickle cell, but many others. And for sickle cell, it was exciting. It did get approved last year. There's 2 modalities, whether you're doing gene addition to have a modified hemoglobin A, or if you're doing gene editing with the CRISPR technology to have an elevated fetal hemoglobin, where you're able to achieve a higher fetal hemoglobin much more than you can with hydroxyurea, which is exciting. It's really great, but it's not available to everybody, and it's quite labor intensive. So there's a lot of preparation of who's the right patient for gene therapy. Do they have an organ disease that's going to limit the myeloablative process, the psychological stress, the impact on the family and the resources? And then once you select the right patient, is getting insurance to pay for it. So we have the price tag on just the stem cell manipulation, depending on which strategy, is $2 to $3 million. That doesn't take into account all the preparation advance, the hospitalization. So it's very expensive. And there's no pathway currently that mandates who's going to cover it, how they're going to cover it, and who's going to pay for it. So for these things, even if your patient has a 20% copay or 10% copay, it's still quite a lot of millions of dollars. But once you get the insurance approval, then patients enter into a treatment strategy where oftentimes they'll go through red cell exchanges to sort of stabilize the disease and help make sure the bone marrow is healthy. Then you get the stem cells harvested. That gets sent off for genetic manipulation. In that time, we're speaking with patients about fertility preservation and whether that's freezing their sperm or their egg or embryos. And then you have a whole set of challenges of who's going to pay for that, how you're going to do that. How do we account for thromboembolism risk with hormonal treatments during that period? So it's not an easy undertaking for patients to really think about. Then once that's done and the product is ready, which takes about 3 to 6 months, patients are admitted to the hospital. They go under 3 days of myeloablative therapy with busulfan. Then they're infused with a product, and then we look for engraftment of platelets and neutrophils. And then the patients are subsequently discharged back to the Sickle Cell Center for care. So we collaborate really closely with the transplanters during this process, and then we resume care of the patients after. And like I mentioned, it's really challenging in patients with chronic pain, because I do have patients who've done gene therapy, but they have a lot of psychological distress because in their minds, they still have the pain of sickle cell crises, but it's not, and everybody tells them, but it's not a crisis, but they still feel terrible. And now society expects them to function like they have a normal life, but they don't know how to do that. So there's a lot of nuances of who is the right patient, how do we prepare them, and what is this teaching us? It's teaching us that we need dedicated experts, we need dedicated centers that really work closely with sickle cell patients in a multidisciplinary pattern to hopefully prime them for this in the future once we have figured out how to do it better. And not all institutions want to do it and become a qualified treatment center because it's very expensive. And we can't quite say who's going to pay for it, how we're going to pay for it. Is it worth the financial contribution upfront? So there's a lot of nuances to go into that, but the data is really impressive. Whether you're looking at CRISPR-9 technology with induction of fetal hemoglobin, it's quite sustained with improved levels of hemoglobin. If you see here, increased fetal hemoglobin, normalized total hemoglobin. Here's a swimmer's plot of each patient that was in the clinical trial. Each of these dots is an acute vaso-occlusive event. pre-treatment and post-treatment, and there's rarely any admissions for acute VOCs after gene therapy. So it's really transformative. It can significantly improve somebody's life. With the other technology, which is gene editing, where you're increasing the fetal hemoglobin, you changing the hemoglobin A to modified hemoglobin A, the vector is transduced and is sustainable. Patients' hemoglobin improved to almost normalized levels 11 to 12, and this is a sustained effect. Again, here you see a swimmer's plot of patients who've had VOCs pre-treatment, quite a few of them, post-treatment, almost no VOCs. This one patient actually had already underlying cardiopulmonary disease and had COVID-19 and had actually respiratory distress and actually unfortunately passed away from that, but everybody else has done well in the clinical trials. But as more patients are going to go through this process, we'll need more data. There's no standard from the FDA that says we have to monitor these patients and track their outcome. So it's really up to each individual provider to monitor these patients and see how they do. In the initial studies, there's some concern for leukemia in patients, and that led to a halt in this process for many years to evaluate that further. And it was thought not related to this, that sickle cell patients in of themselves have increased risk of neoplastic progression. And so it's not really so much the treatment, but maybe the condition process could halt that, sort of increase that. Again, there's no guidelines from the FDA that says we should evaluate for clonal hematopoiesis and any of the sort of neoplastic risks in patients. So there's a lot more that we need to figure out in the sickle cell community of selecting the right patients for this. This just highlights again some of the other clinical trials. So while currently we don't have a lot of disease treatment options or FDA approved, there's a lot more studies ongoing and targeting various aspects of sickle cell, which is exciting. All right. Now, to talk a little bit about the burden of sickle cell disease and sickle cell centers, which is one of my favorite topics. So sickle cell disease has a high burden on patients, loss of vitality, loss of quality of life, and truncated life compared to other diseases. Patients have significant impairment in their physical functioning, their physical vitality, their ability to just feel a sense of well-being compared to the general population. Furthermore, they have decrease in social functioning, emotional dysregulation, and some mental health concerns, and that really does impact their education and their employment. Furthermore, patients with sickle cell disease oftentimes live in food deserts, in underdeveloped areas, or areas with poor access to care. So those patients are, they don't get the treatment that they need. They don't get the care that they need. Subsequently, they have higher healthcare utilizations and ED visits, and you can see that in the inner cities. In my clinic, I used to go to Costco and just buy boxes of snacks because they would come in and they do their labs and they're like, frankly, hypoglycemic, even though their white counts are okay. So you knew and they'll be like, well, I haven't eaten, or I had to pay for an Uber to get here. And so it's really devastating to have these patients in the DMV area without proper access to care and food and utilization. And so it's not unique, and this is the most resource-rich area of the country, in my opinion, and we're seeing that. So imagine some of the more urban areas where they're really seeing the impact of the social determinants of health on disease management. So a lot of sickle cell patients are in the Northeast, East Coast area. New York and Florida have the highest population, but they have the least dedicated sickle cell centers and programs. I've had patients who relocate to these areas, and the hematology oncology clinics that they call to establish care just tell them, sorry, we don't see sickle cell patients. Or if I plug them into a sickle cell center, they have to drive 3 to 4 hours just to get there. So it's very challenging to plug people into care. We've looked at, so we're part of what's called the National Alliance of Sickle Cell Centers that I'm really excited and proud to be a part of. The goal has been to really develop, in collaboration with the American Society of Hematology, train and develop young experts in sickle cell disease that then can practice in the community, whether it's community-based or academic-based. And we're exploring different models of care, whether it's a hub and spoke model for rural areas or more designated center. As you can see, the programs are starting to grow across the country, but there's still a lot of gaps in care. The blue represents pediatrics, the red represents adult practices, and the purple is lifespan. So we're growing, we're training more and more people to develop these centers, but there's still a lack of appropriate centers where patients live. But there's data that really does show that patients who are plugged into care do a lot better than patients who are not in care, which I think we all can know that. In Virginia, for us, a lot of our patients are in Northern Virginia, where we are located, in the Richmond area and then the Tidewater area. So based on that, the state has allowed for funding for centers to develop. In Richmond, Dr. Wally Smith, who's a well-known expert in the field, has had a program about 1,000 patients for quite a while. But that was the only program in the state of Virginia until we came along for Northern Virginia in 2022. And then we're helping the Tidewater area develop. There's about 400 adults displaced currently that don't have access to adult care. Then they just developed a center. The state of Virginia is starting to, it's going to mandate a statewide registry from all healthcare institutions to keep, so we can actually know how many patients are in our state that live in with sickle cell disease. But our data so far kind of mimics what we know nationally. So 1 out of 325 African Americans have sickle cell disease, and 1 out of 12 have sickle cell trait. But only 14% of patients who have trait actually know they have trait. So that's a significant amount of people with trait who don't know they have trait. So the chances of them meeting and having a baby is quite high without like really knowing the education and the understanding of that. So I think that's why the state is working really hard to do that. So with that, I want to talk a little bit about our program and why we started. So you can see there's a huge need in Northern Virginia to have a dedicated treatment center. There's really wasn't anywhere for them to go. Patients didn't want to drive all the way to Richmond. Howard was getting really saturated. DC was getting very saturated, and Hopkins was like too far for them to go. So we obtained funding from the state of Virginia, as well as Inova to start our program. And so right now, I'm the only person that's there full time. We have Dr. Ursher, who is there for a long time taking care of sickle cell patients. He's since retired and kind of serves as an emeritus professor. We have somebody who does primary care. He's there about 0.3 FTE of the time, so a day and a half to help us. We had an APP that we lost, unfortunately, but we're getting another one. It's really hard to get people to stay in this space, whether that's your social worker, your nurse, your clinicians. I love sickle cell patients. They're wonderful human beings, but sometimes it can be a little bit challenging if you don't have the bandwidth for it. So I always say you have to have the right people in the right field. And if that's not for them, then it's fine. Go, I love that you figure out what else is for you. But the rest of the team has been really wonderful, and I'm really looking forward to growing. But we've made significant improvements across Inova that I'll share some of that data with you. And it really demonstrates how developing a program will attract patients, will keep them out of the hospital, and will improve quality of life. So we're located within the Inova Shark Cancer Institute, and where we now have access to all of their resources, which is fantastic. So we use their infusion center to do acute care treatment, whether with IV fluids and IV pain medicine, somebody who really needs a transfusion, or the crizanlizumab infusion. We have an apheresis unit we collaborate closely with, and patients who need exchanges, whether that's chronic or acute. We have a pediatric department right above us, so the easiest transition is just one elevator down to the 4th floor. So we are able to quickly transition patients. We also transition from children's as well. We collaborate very closely with VCU, Hopkins, as well as the National Alliance of Sickle Cell Centers. So for every patient that we have, we've developed what's called My Sickle Cell Passport. Each patient has an individualized care plan for the ER and the hospital. It shows them what treatments they're on, what complications they've had, what all the screening and organ assessments they've had. And it really helps us teach them about their sickle cell disease. In the adult world, we do a lot of unlearning of the things that they learned to do for their sickle cell. That's not really the right thing to do. And so having these tools really helps. Each patient gets what we call a care plan meeting. We bring the patient in and their caregiver. We go over through their disease trajectory, where they are, and our goals for them. And then we meet, especially those who are really sick, and we meet weekly to kind of go over that and reinforce what we talk about and help them with like disease modifying therapies. And we've really quite seen improved patient outcome. We've also gone through all of our 5 hospital systems and done hospitalist ED and nursing education to standardize the sickle cell care. We've developed an EMR group chat where they can message us directly and we can lend support. We work very closely with our inpatient hematology colleagues who round on our patients. So, we sort of serve as the bridge between the outpatient and the inpatient setting. And then we do a lot of clinical trials. We do community outreach. We do a lot of events with CBOs to really bring patients into care. So, we started not out of the goodness of anybody's heart to form a sickle cell center, but it was more of like, hey, these patients are really staying for a long time in our hospital, are driving a lot of our, negative hospital metrics. What can we do differently? And so that's where we started. And since 2022, when we started, the sickle cell admissions were going up and up, and that's the trajectory. And then we started, and we've been able to curb that significantly. We see this dramatic reduction in sickle cell admissions over, even within the first year. And that's been sustained since then. One of the things we looked at was that because we have so much control over the Virginia patients, we take all comers, commercial insurers, Medicaid, Medicare. Even if anybody doesn't have insurance, there's a charity expedited program to come into a program. So anybody who lives in Virginia, we have a lot of aggressive control over their disease and their outcome, versus the Maryland patients, we do not. So they have DC and Maryland, they're Medicare, Medicaid, we can't really see those patients, but they frequent our hospital system quite a bit. So as you can see, since we open and we've been able to improve the care and bring patients outpatient, or admissions have dropped significantly in the state of for Virginia residents, but it continues to rise for the Maryland patients because it's really hard to discharge them to where, who's there to receive them, who's there to really work with them, and we don't really have strong connections in that regard. This is another way of looking at length of stay for Maryland patients versus Virginia. Virginia patients an average about 6 days. That's sort of starting to mimic more of the national average. We still have a lot more work to do in this regard, but certainly better than the Maryland patients who stay at our institution for 9+ days. And it's because they have high 30-day readmissions and really, really sick, and no close collaboration with the outpatient teams. In terms of ED utilization, since we started, the admission ED use was going up for sickle cell patients. It started to come down since we started as well. So our ED colleagues are pretty happy with this. For our patients, everybody has an individualized care plan. We're constantly adding, modifying, changing these care plans. We use Epic. So as soon as you open a patient's chart, there's a patient advisory pop-up that you have to acknowledge to escape that, and tells you this is a sickle cell patient, this is their care plan. It has everything, how to transfuse when and how, what do they have alloimmunization and antibodies, what to do for them for pain in the ER, and then upon admission, what to do for fluids, what to do for itching, and all of these things are sort of become an issue. There's also like what we call an FYI flag, and it's in our notes, so you can't miss it. It's everywhere. What we developed as well was a sickle cell order set within our EMR. So anytime you're admitting a sickle cell patient, you just follow this order set, and it became really easy to standardize the care. I put in this order set guidelines for PCA, especially for patients who don't have a PCA protocol already, because we don't want anybody getting intermittent IV opioid bolus dosing. And so we wanted to give hospitals at all of our hospitals a chance to use this, even if the patient doesn't have it, and build upon that. We put in some general education and precautions based on the experience we've had where patients have had adverse outcome. So thinking about stroke, VTE, how to manage a fever. So that order set really outlines for you what you need to know for that patient and what to do for sickle cell. One of the biggest things that we did that required a lot of work and was really challenging was the IV Benadryl, trying to take that away from patients. Because historically, patients came in and they got the cocktail of IV Benadryl, IV Dilaudid, and IV Phenergan. And it makes sense that they want it. They're miserable at home. They're like in so much pain. They just want to come in and provide relief. And if that is a little euphoric for them, they're like, I need it, right? So for us now, we've had to come back and take that away from them and show them this is not appropriate. The mechanism of opioid-induced pruritus doesn't actually need to be treated with IV Benadryl. And so that was like a really, really hard challenge at our institution. We had a lot of fights. I had patients hit me. I've had patients throw chairs. Like they're really, wanting this. But over the last 2 years, the more we fought it, the more they sort of like, now they know it's standard. They don't even ask for IV Benadryl at all, which has been fantastic. And we've already seen really improved outcome. I've had patients get admitted and been inappropriately given IV Benadryl and intubated from that. So it's a very serious thing. So we've had to really work with patients and hospitalists and ER doctors to take away the IV Benadryl, which has made a significant impact on admissions, lengths of stay, and hospital readmission. If you remove that incentive, if you teach patients what's proper sickle cell care, they eventually follow along. Because ultimately they don't want to be in the hospital. And I'll show you some data about that as well. But if we take away something, we have to give something else, right? If you're admitting 10 patients that day, you have the bandwidth to have this IV Benadryl fight? Probably not, right? So we put in that same order, said what other agents to use. So the oral, diphenhydramine, the oral hydroxyzine, patients who can't say, they're nauseous, they're vomiting, they can't take oral, will use the IV nalbuphine or a really, really low dose naloxone drip. That actually is pretty effective. So we negate around the whole, I can't take, something oral, I'm nauseous, so you can give them something IV as well. And this has really helped us organize the care, standardize the care, so patients are not going from one hospital to another thinking they're gonna get something differently. Simultaneously, we've had a robust increase in clinic visits. A lot of patients have come to our institution and have established care. So our clinic volume and outpatient growth, this is actual clinic visits, have increased dramatically since we started. And since we started, we're basically comparing everything to 2021. So we've increased hydroxyurea utilization dramatically. We used a lot of oxalitor, which we are not using at the moment. We use a crizanlizumab. One thing we've done very aggressively is work on the chronic pain with patients and transition them off from full agonist opioids to partial with buprenorphine. Sickle cell patients are not seen by palliative specialists. They don't really want to see sickle cell patients, and a lot of pain management practices either don't want to see sickle cell patients or don't have that nuanced understanding of sickle cell. So we've kind of taken on the pain management aspect as well, but we've used buprenorphine with quite a bit of success. It doesn't have the same side effects as full agonist opioids, and if a patient goes into a crisis, you can hold this, treat them, and then kind of get them back on this. We've also increased use of chelation and recognizing iron overload and how to manage that. So this was just an example of you build the clinic, patients will come, you can improve care with disease-modifying therapies and in-organ screening assessments. This plot shows some of our 10 highest utilizing patients in our health institution. Each color represents an individual patient. And I used to admit some of these patients who were just a revolving door. Some of them were in the hospital 60% of the time. So when we started, we took on these 10 highest utilizing patients and we worked very aggressively with them to put them on disease-modifying therapies to really control their sickle cell disease, to teach them about proper management of your sickle cell disease. And as you can see by 2023, that each of their individual admissions has improved dramatically, really, really quite dramatically. And I will show you some examples. A 39-year-old with SC, he was in the hospital quite a few times. If you look at 2021, based on each quarter, the amount of days he was in the hospital. When we met him, he was really angry at us for taking away the IV Benadryl and the opioid pushes. Really angry because he said, you don't understand my sickle cell. This is what works for me. How dare you do that to me? And we had to really work with him. What I found out was he's very, very anxious individual. So he was worried that he was going to die at home from sickle cell disease because all his life, he said, I was given a number and they told me 19 was my number. When I'm 19, I'm going to die. I probably won't make it past 19. So any ache and pain he had, he would just go to the hospital, right? And then he would just subsequently get admitted. And he had 2 daughters and a wife, and they didn't know how to navigate this with him because they don't want to lose their loved one. So they supported him in whatever he wanted to do. So to bring the family in, talk about sickle cell disease management, talk about why we're going to use a PCA instead of IV bolus dosing, work with him every week, get him off of his Ativan for anxiety, get him on proper treatment for anxiety, work with us and help him understand the triggers for sickle cell was like remarkable. He has not been admitted. He will come in every time, like, see, I'm still out of the hospital since 2023. This is huge for this man who's spent so much of his life. He now volunteers his time at his children's school. He goes on vacation with his family. So it's not so much you just improve hospital metrics. You're improving somebody's life, things we take for granted. I can plan my vacation and not worry about, am I going to have a crisis, right? This family couldn't do that because they never knew when they would have to cancel a trip. Now they don't feel like they have to do it in that same way. He knows he's undergone cardiac monitoring, pulmonary monitoring. He's gotten the vaccines he needs. His renal function's been assessed. Every organ has been assessed. And then we teach them outside of that, life is unpredictable, but you got to learn to live with some degree of unpredictability like we all do. But it really, really helps. You can't do that on the inpatient side. this is things we have to do in outpatient. So that's why having a dedicated outpatient team is so important and labor intensive. But I mean, it's just beautiful, right? Like when you see people flourish and blossom and, they don't want to be admitted. Patients don't want to be in the hospital. And I think sometimes we forget that. Here's another patient, a young woman, 28 years old, so spending 60% of her life in the hospital, quite a bit. It was the same thing, bring her in. What we did with her was very aggressive, but we put her on a red cell exchange protocol every month. So we removed all her sickle cells every month and gave her hemoglobin A. So anytime she had a pain exacerbation and wanted opioids, we told her, this is chronic pain. This is not an acute crisis. We're not going to give you that. So even though she was getting admitted subsequent to that in a hospital, we put in the ER and the hospital, no IV opioids. And so she learned over time she wasn't going to get it. And she had to really kind of work with herself and figure out what is chronic pain and what is not chronic pain. And she basically had to work with us, with our talk therapy group and our social worker, to walk through some of the medical trauma and the PTSD that she had. And that's really went well. She started having a full-time job, which we never thought she would, but she did. And she has a college degree. She was able to use it. And, these subsequent admissions were mostly for pneumonia and other non-sickle cell related admissions. So it's like really impressive to see her grow in that regard. So with that, I just wanted to say thank you for listening to me talk about something that's very near and dear to my heart. I think what everything is teaching us is that we need more dedicated experts in sickle cell programs to work with patients very closely. And if we do, everybody wins. The patients wins, the healthcare system wins, and we need more disease modifying therapy. So with that, thank you, and I'll take any questions.